I know will be a really exciting talk and hopefully discussion too, because I think I've seen bits of this in the early stages, and it was really cool to hear back then, and so I'm excited for this morning to hear where it's going. And I'm just going to let you take it away.
Thank you so much, Annie. So Annie, thank you. That was a lovely introduction. Annie was my third-year resident when I was an intern as residency at UW. And Annie will remember this. We were on my oncology, our inpatient oncology rotation together with an extremely traumatic is maybe not a month together, where we had a lot of really complex things that we
you can say it. I still have PTSD from that month.
It was quite a month together, and one of the main reasons I went into palliative care. So, and Annie really got me through that month. I don't think I would have survived without her that month. So, wonderful. Thank you guys so much. It's so fun to see so many familiar faces, and also in some new faces. I think Shanitra might have said that we maybe have some interviewees on this morning. So welcome. We're really excited to see all of you. I am going to be doing this talk. This is a really interactive talk, so we'll kind of show in a minute, but hopefully people will feel free, get your chat box kind of warmed up, because I'm hoping that this is going to be kind of a discussion type engagement this morning. So I'm going to be talking about how we kind of tailor our response to the do everything request that we can get, especially when there's prognostic discordance, and how do we maintain alignment in those situations with the people that we're serving. And so that is what we're going to be talking about today. This is something, as Annie has mentioned, she sees me kind of play around with this chalk talk when I'm on service with our learners. And I finally put it together through, I did this presentation a few months ago for Project Echo Cares, which has been kind of a national program to train palliative care teams on the kind of East and West Coast. So some of you might have seen that during that presentation. Hopefully you still get something out of it today, if so. But anyway, I hope, again, as I mentioned, that this is a really interactive talk. I don't have any sort of financial disclosures to disclose. I do get nonprofit funding. I have over the years, both through the Cambia Health Foundation, and I am faculty for Vital Talk. So just to kind of provide that background. So today, a couple of things that we're hoping to do today. I am hoping that at the end of this, you can list common reasons that prognostic discordance occurs. I hope that you can describe a framework for identifying different types of prognostic discordance, and then describe some communication skills to maintain alignment when that discordance is present. So as I mentioned, this session works best with you involved. So I'd love for you guys to open up the chat box now and say hello. Let me know kind of what your professional identity is, how you describe that in your mind, just so I get a sense. A big part of my work is interprofessional collaboration. So I'm hoping to just see who all we have out in the audience. And what setting, where do you practice? Are you inpatient? Are you outpatient? Are you adults? Are you pediatrics? Or somewhere in between, family medicine, whatever those are. So go ahead and just pop those in the chat box. Awesome. Carol Cummett, I see, is on. Hello, Carol, who's been one of my mentors from early on in fellowship. Fabulous to see you. We've got people over at Seattle Children's. Thank you, Arika. Oh, we've got some spiritual care providers. I've seen some fellows, people at the VA. Oh, these are coming in hot. All right, fabulous. This is wonderful. Some nurse managers, our trauma coordinators. I think Andrea said they're both there. Good to see you guys. I've got a rabbinic pastor student. That's fabulous. Wonderful, you guys. So good morning. And a lot of people are already putting in the chat box. So this is going to be great. So to kind of get us started, I'd love to hear from you guys. What do you, from your perspective, what is prognostic discordance? When we say that, what do we mean? What does that mean to you? So go ahead and pop that in the chat box. Okay. Yeah, this is great. Give you guys one more second to respond. Yeah, so these are great. So a couple of things coming out here, and again, just kind of welcome. I see we also got folks from our applicant pool who are really covering the span of the country, so that's great. So a lot of people are talking about when we have maybe different ideas about what the outcome might be. So especially when the family is hoping for something that the medical team disagrees with, we have different ideas about what the likely outcome would be. Have been some of those when we're not on the same page, right? So what is ideal versus what is possibly reality of what might happen. So that's right. So in studies, when they've looked at this, how they kind of define this essentially numerically is when a family might have, and we're going to specifically kind of talk about surrogates in this. So surrogates are family trusted others of our patients, when there's more than a 20% difference in what we think the outcome will be. So when patients or when families or surrogates are 20% more optimistic than we might be about what the likely outcome might be. So in kind of thinking about that is oftentimes what we hear from the families is do everything. We want you to do everything possible. And often what we hear from the clinical team is they just don't get it. And we might even say the dreaded, they have the D word, they have denial, which is not generally, I hope by the end of this, you'll realize that denial is often not what's going on, right? Is that they're very much aware of the situation, which is why they are pleading with us to do everything, right? Is because they actually really get it. And so what do we do in these sort of situations? So before we start, I'm going to try to launch a poll. We'll see if this works. Is what percentage of surrogates express doubts about our ability to prognosticate in critically ill patients? So how often does this occur? So I'm going to launch this poll. We'll see if it works here. And your options are less than 20% of the time, 30 to 50%, 60 to 80%, or over 80%. All right, I'm seeing the results come in. I'm going to share them in just a moment. It's very interesting. We're seeing kind of things all over the map here. I've got about 30 people who've responded. So 35. Okay, whew, this is a good group here. All right, so I'm going to go ahead and end the poll for time and just share these results. So you guys were kind of centered around that 30 to 50%. You've got another portion who's at 60 to 80, and then we've got some kind of at those tail ends. All right, so hang on, stop sharing. Okay, all right, so let's see what that answer is. So actually 88% of surrogates express doubt. I mean, that number is was pretty striking to me when I was doing this research. So actually the vast majority of people that we are taking care of express doubt in our ability to prognosticate in a critically ill setting. And about 50% of them were more optimistic. So even if there's about half who say, even if I have doubts about their ability to do that, we're still kind of about on the same page. But about half of them are going to have a more optimistic prognosis than where we are at clinically, right? So I think this is something that is really, really common. And I think something for us to be aware of, that this is almost just kind of something that's inherent to our nature, right? To kind of question things and to wonder about things. And to have, I mean, in our life, we have disagreements about different things all the time and different opinions, right? And people who are important in our lives. And so, I think it's really important for us, given how common this is, to really be aware of what are some of the underlying reasons for this. So pop in the chat. You guys are doing such a great job of using that. What are some reasons why surrogates may disagree with our prognosis? Where does that come from? Throw your ideas out there. Hope, trust, faith. Ooh, good. Yeah, we haven't been as long as this patient's, I love this from Sarah. So we haven't been as involved in the patient's life as long as they have, right? Oftentimes they know something about their loved one that we might not know. They did their own research, Elise says, right? Yeah, right. They know their loved one better than we do. Details versus big pictures. Previous experience where prognostication was incorrect. Nora, I mean, how often does that happen? We know we're not very good about it. So we're saying, gosh, your loved one is dying, and then they don't. Your prognosis is 3 months. We put the specific number and they live 2 years. This sort of stuff happens all the time, right? They've heard of other people that have had some sort of recovery. These are all great. Grief, Deborah mentioned, right? So these are really great. I think fear and mistrust of the healthcare system is really, really a key one. So these are all great. We're going to highlight, want to kind of keep in mind some of these I wrote a few of these down, and we are going to kind of go over those in a moment together. But before we do that, I want to kind of look at least what does some of the research tell us about where some of these reasons are coming from. And actually, you guys really, I think you covered most of these. So I'm just going to kind of summarize those as kind of what's underneath that plea to do everything. So Doug White has done a ton of work on this. He's a big collaborator, has been with Randy Curtis over the years, and works in critical care and does a lot of things around surrogate decision-making. So a lot of the studies are from Doug's team, but this is kind of how surrogates prognosticated one of the studies that Doug did. So 64% of patients people looked at the patient's appearance. About a third of people felt like there was the power of optimism, intuition, their faith. 30% mentioned that there was some unique or intrinsic quality of their loved one that we didn't really know or understand, which you guys mentioned, right? They know the person better than we do. The previous track record, we talked about that. And then the power of bedside presence of them being there. And then 4% mentioned the specific belief in miracles. The interesting thing about this study is actually only less than 2% relied solely on the physician's prognostic estimate. I put MDs, I should have said physicians or medical teams in here. So that, again, that number, because I bet if we were to poll clinicians, we would think, gosh, this number is closer than, 70, 80%, because the vast majority of time we have family conferences is because if we just give them more medical information, we're going to get there, right? And in fact, actually, the vast majority of decision making, very little of it is based on our kind of perception. I mean, they take that in, right? They take it into account, but a lot of their overall decision about where they think the prognosis is going to be is based on all these other factors in their life, which makes sense in terms of how we make decisions in our life. So in some other studies, they said that the sources of discordance were factual misunderstandings, so those are there as well, but emotions and belief factors or both were very common. And the most common reasons for optimism were maintaining hope. That was a big thing that mentioned as beneficial to patients in themselves is a way of coping, right? And that the patient has unique strengths and that religious and faith beliefs were a big part of that. So these were some of the big reasons. So what I'd like to do, interesting that appearance. Yeah, Susan. So Susan mentioned this in the chat. I'll try to keep an eye on the chat, is that Susan mentioned kind of the appearance. And I think one of the things that we have realized, and in fact, I feel like maybe I even saw a study about this, that in COVID, where it's been really hard for families and visitors to actually come in and see their loved one, that teams have been feeling that it's been even more challenging to kind of be in prognostic alignment because of that. And that kind of explains why that's happening, right? So we're going to talk about some of these reasons here. And what we're going to do is we're going to actually together, we're going to fill out this table. Okay. And there's a lot of reasons. You guys mentioned a whole bunch of reasons why people have prognostic discordance. And we're just going to cover a few of these today. We don't have time to kind of cover all of those reasons. But what I'd like to do is introduce this framework to you and see if we can start to think about this a little bit more intentionally, that when prognostic discordance, when we see that that's happening, can we start to identify what are the underlying reasons for this? Because our intervention, our response to that needs to be tailored with what's going on underneath. And our skills can be then really specific to that. So what we're going to do is the first column is kind of what we hear, what we might hear from the patients or families. I might fill in some of those things for us. But the second column is going to be this idea of outcome versus process. And what I mean by that is some of surrogates or patients are really concerned about what the outcome will be. Will I be able to, get better? Will I be able to walk again? Will I be able to talk again? Those kind of functional outcomes that oftentimes we're really worried about. And sometimes patients and families, that is the most important thing, is what is the outcome after all this? I'm going to go through all this. Am I going to get to where I want to go? The process, though, is how do I feel? How am I being taken care of in the process of the interventions, in the process of whatever the medical journey is that I am. How does it feel for me to go through the healthcare system to be being cared for by people? So for some people, it's more important. What does the process feel good? Do I feel cared for? Do I feel heard? Do I feel tended to? Both of these things are important. So I don't want to think, but if we think about these things, is there one that becomes more important than the other? So I want you to be thinking about that. And then what are some of the communication skills or strategies that we can use? And then the last column is family conferences. As we think about the intervention of family conferences based on these different types of prognostic discordance, how do we utilize that tool? How do we best utilize that tool? Okay, so those are going to be the things that we're going to talk about. I'm going to fill in the first two really quick. And shoot, I was hoping I would do this, not quite share them all the first time, but I'm going to put in these first two, which are, the first one is when there's a true information gap. Okay, hang on, I'm going to go back for a second. So as I mentioned, a lot of times clinicians think that the most common reason why there's discordance is because there's an information gap, right? And so we're like, okay, if I can just give more information. And so sometimes there's truly is an information gap, right? We know we're not very good at explaining medical information, or they've heard this from one person and then someone else came in and told them something different. So that is really common. So what they might hear is, well, we heard this, or I don't understand, or what do you mean? This person said this and that person says that. That's what we're going to hear from the patient or family, right? If that's there. Or we might hear them kind of report information when we do that really good assess question that is different from where we're at, right? Oftentimes, there is an information gap. Is if we can provide the answers to those information gap, our alignment can get back in alignment, right? Because oftentimes those people are really worried about the outcome. And once they really understand the outcome from our perspective, then we are usually on the same page, right? And so the communication skills we have, I just mentioned this, is assessing understanding, right? Really trying to get at what have they heard already so that we can fill in any details. We ask for permission before we give information. We use things like a reframe or providing things in a headline that has information and meaning. We might use best case, worst case scenarios. There's, some other ways that we describe. Some people use the ask, tell, ask tool. Those are some of the communication tools that we would use to fill in an information gap. And in a family conference, one of the most important things about our family conference is a pre-meeting, is that we get on the same page, right? Because if we're not on the same page, it's hard for our patients and families to be on the same page. So having a pre-meeting, getting everybody there, and actually meeting, having, facilitating specialist messages, assuring that you have interpreters there, that you're working with them so that we can really make sure that that information is getting communicated when English is not the primary language. Those are all kind of some of our tools around the family conference. The second one, which I'm also not going to spend as much time talking about, is grief. So some of you mentioned that. I think I saw that Deborah mentioned grief, right? Is that a lot of times people have a huge grief reaction, especially when they're just processing information. And that can be the thing that is the big barrier to the initial prognostic discordance. I've been on a lot of family conferences where I've met with a family and there've been a huge grief response. And I think, and the team's saying they don't get it. And then I meet with the family, and then a few days later, I meet with them again, and they're in a really different place. And I didn't necessarily do anything differently between those meetings. They just had time to really kind of let the information sit in. So what we might hear from them is, I can't believe this. This is my fault. I can't lose them. How am I going to manage without them? Those are all cues to us that there is an emotional processing that's going on. People who have been estranged for a long time, and this is what they're coming back together. Those are all things that we're going to need to have different interventions for. Outcome is usually also the main concern here, but the process of how we care for them is going to be really, really critical. I mean, it always is when we have high emotional states, but in particular in this. And so responding to emotions using our nurses' tools, silence, I wish, using informed assent, which is a lot of times when people are emotionally flooded, they might actually be ready for you to make a recommendation if you get the sense that's where they want to go, but they're emotionally the emotional barrier to feeling the weight of making a decision for a loved one is the main thing that's preventing them. Then they might be open to making a really clear recommendation about how to proceed. And I think the key thing is it may not be that they need more family conferences in this sort of situation. This is, how do we really make sure that we're pulling in the interprofessional team? If there's spiritual distress, there's emotional distress, if you have a psychologist, a child life therapist, who do you have on your team that you're working with who can help them process this information, and to slow things down, right? They're going to move at a slightly slower pace than when we're really ready to make decisions. So can you kind of slow things down for them so that they don't feel so flooded in the process? Before I go into these other ones, I see new messages. Let me just check yeah, great. So Deborah's, yeah, exactly right, is to have that spiritual care person there as well. So I'm going to pause there about just those two. People feel free to unmute or put in the chat box if there are any questions or comments just about these first two. All right. Okay, so what we're going to do now, I'm going to stop sharing for a moment here. Hold on. So what we're going to do now is we're actually going to, I just got to change my screen here for a minute, is we're going to actually fill in, these other two here, or these other three. Hang on, sorry. And I'm going to put in, so a couple of that you guys, that you brought up, when you guys felt like what were some of the reasons for prognostic discordance. So one of the ones we're going to do right now is when they've had a different experience. So a lot of you kind of brought that up, right? Okay, so let's go through this one. Hang on, let me just share my screen. Okay, all right. Okay. All right. So can you guys see that? So, so when people have had firsthand experience, so this is where, right, they've been told something, but they're like, my loved one, something that, they've already gotten through this. The last, clinician said that my husband wouldn't get better, and look that he did, right? There's some sort of firsthand experience. So, so what are other things that you might hear from them that they might say? And I'll go ahead and pop these out. Yeah, they got off the vent last time, right? Put that in here. What other things that you might hear from them? Yeah, I love it. They're a fighter. Great. Okay, yeah. Okay, so these are great. Okay, all right. Yeah, so there might even be a belief in miracles because they've seen it happen, right? They've actually experienced the miracle firsthand. So what, for these folks, is outcome or process more important here? Yeah, Mira says outcome, yeah. Yeah. Okay, I'm seeing outcome. Anyone else want to vote on that? I love it. Okay, I figured if I waited longer, there'd be a couple more process out there, right? Okay. Okay, so this is great. Okay, so in some ways, this almost starts to be about kind of even, right? Is both of these are really important, because ultimately, oftentimes, if you really dig down, these don't tend to be people who are longevity at all cost. right? They're not necessarily people who'd say, even if my heart's just beating, as long as I'm alive and I'm on machines, that's okay with me. Outcome tends to be important, but the process is really important here because they're basically saying, hey, you got to give us a chance. We don't really believe you, and we need some more time to really see. We need to see for ourselves what's going to happen here, right? So these process and outcome are oftentimes kind of pretty equal here. Okay, what are some of the communication strategies that you can use when there's a firsthand discordance difference and process and outcome are equally important? What can you do? Okay, so ask about the experience. So Kathy mentioned tell me your understanding. I'm gonna even push that a little bit further, which is, can you share with me this prior experience? Right. So Charmin just put that in there. Talk to me about what's happened in the past so that I can really understand it. I really remember we were at one of our annual palliative care conference. I forget now what talk I was giving, and I had this woman come up to me, and she said she was really worried. She says, I've got this patient that I'm taking care of in a long-term care facility, and he's got severe COPD, and he really wants to be full code on his pulse. And I've been trying to convince him that is just not a good idea. And I said, okay, I said, tell me a little bit about experience. Why do you think that that's so important to him? And she said, well, he had CPR and he was on and I'm like, you didn't even need to tell me anything else, right? This guy has already had CPR and it worked. Why would anything that we would say ever convince him otherwise that wasn't a good idea, right? Because from his experience, that was a really helpful intervention. So this is great. Like, tell me about your experience with this before. Okay, great. Okay, so I love it. Ooh, I love the align with hope. So we're going to put align with hope. Great. We're hoping for that too. Okay, good. I hope I worry. Okay, so that might be something we do when we provide our medical information, when we do that. I'm really hoping for that too. Is it okay if I share a worry I have so we can kind of express that alignment, but also share maybe those underlying worries? Okay, great. So tell me why he's a fighter. Tell me more about that, right? Oh, and getting at some of the underlying emotions. So I think that's always one of those things, what is underlying that, right? So, I've had situations where maybe I had a recent situation where I had a daughter who was an only child and her father who was very sick with COVID. I mean, that was it, right? So yes, there was this experience difference that he had, in fact, actually had some other experiences in the past where he really had done better than what providers have said. But then she was really terrified about losing him as well. So, okay, so Charmin then highlighted the key thing here, which is time trials. Okay, so I am going to bold this. Thank you, Charmin. Is that really at the end of the day, if experience is the most important thing for them, actually giving them some more data, they need data more than they need words. So they need to actually experience things firsthand. And this could be actually for those of us who I work at Harborview, which is a kind of our main trauma and stroke center. So we work a lot with traumatic brain injury, and stroke is coming in and actually having them do the neurologic exam with you and saying, let's do that exam together. And now these are the things that we're going to be looking for together as we move forward that are going to tell us that neurologic progress is happening, that improvement is happening. So a time trial is about giving an anticipatory guidance about what are we both going to be looking for that are going to tell us that your loved one is getting better. What are going to be the things that are going to be worrisome, that make us worried that this person is not going to make the improvements that we're all hoping for. The beauty about time trials is that I love time trials in part because we are often wrong, right? And I see this time and time again, is that we think the prognostic outcome is really clear, when in fact, actually, the outcome isn't always as clear as we think that it is. So doing a time trial both allows us to align to where the patient families are. It also allows us to be open to other possibilities too, right? And then we really get to like join in the hope together and do that together. And we've provided that anticipatory guidance on both things. So we can also share in their grief if what we're hoping for doesn't happen. And now we're really walking together in that alignment piece. Okay, so what about family conferences? Are family conference helpful, or how do we utilize family conferences in this? Okay, so we're going to outline the time trial, then give it a rest, right? Okay, then wait. I'm going to put, yeah, patiently. We're not going to schedule another one the next day and be like, oh, but do you really think, are you sure? You know? All right. Emphasis on family. Great, so we're going to provide family support during this. Okay, explore differences in perception. Okay, great. Okay, all right. So David, so not everybody might be on the same page as a family, right? So we might spend some of this time getting to know kind of different perspectives or hearing different perspectives, right? Okay, I like that. Some of the experiences might be different. Okay, we have to, yeah, over the head, right, with information. Okay, so Arika said that we have a tendency, right, to then just give more information, right? So this kind of goes back to the idea of set up the time trial and then step back. And you might provide that information. The daily basis might be kind of, let's see, kind of, are we meeting those milestones we talked about? But what I also really like to say, oh, so Megan just said this. So Megan said, regular check-ins and touch points. So the key about this is that the difference between, if there's an information gap, I can have a family conference when there's only worrisome information that I need to share, right? But when experience is one of the big differences, what I want to do is I want to have regular meetings that are at intervals where if things are going well or when they're not going well, right? So I want to be able to do both so that we can celebrate in the successes together and we can share in any loss together, kind of on a regular basis that meets the family schedule, as long as that is therapeutic to them. That doesn't always, sometimes we want to do that and that may not be therapeutic to them. So you want to check in with them about that. But that is one of the ways that you can do that and set up whatever it is that you're going to meet again, or however you're going to kind of do these intervals together. Okay. So let's talk about these, yeah, is it okay if we come back and check in tomorrow, right? And so some of these might not even be a big family conference. Some of them might be some more of the bedside kind of one-on-one kind of check-ins as well, okay? Okay, so the next one I want to talk about is when there is, when people, you guys mentioned this, when there is mistrust in the system, there has been an experience of discrimination in the system. So that's the next one that I want to talk about. Okay. Mistrust, right? Okay. So what might you hear? What might surrogates say to you when this is a primary concern? Okay, all right. Use one. Okay, oh, you're rushing. Okay, these are great, okay. Ah, thank you. So Shobha mentioned you might not hear anything, right? Thank you. Okay, so I'm gonna put that. So thank you. I was gonna say that, but I'm so glad. So Shobha mentioned that, right? Is that sometimes this experience is not clear. So we have to be really, we have to almost assume, right, that this is happening in our systems, because we know that this is something that is a major problem that fortunately we have come to this moment in history where I hope that we are finally kind of addressing a lot of these issues that we all know have been present for generations and generations in our system, right? So we have to be really attuned, and we almost have to treat it as if everyone has experienced discrimination within our system. Because then what I want want to use, I mean, people experience discrimination in our system because of racial differences, religious differences, economic, sexual identity, all of those sort of things are ways that people have experienced discrimination in our system. So, so some of the other ways I want to just mention, to negative encounters. Yeah, so these are great. And I'm not even going to have room to put all of these in here, but I think having negative encounters with clinicians. One of the big ones that I see is really strong advocacy. So is that people have to, or hypervigilance, is they feel like they have to then be at the bedside for every moment and be paying attention to kind of every piece of care, because they have to make sure that their loved one gets the best care possible. So that's one of the other things that I really pay attention to, because they're worried people aren't really listening to them. And so that something might happen if they're not there. So that is one that I'm just going to kind of add on here. Okay. Okay, so what about outcome versus process here? What's more important? All right, we've got a pretty good consensus here around this, right? So, and I don't want to say outcome doesn't matter, because again, as we know, obviously all of us want that person to be getting better, and that's really important too. But the process of care, we should be doing this with everybody. That the process of care is particularly important here, is that people feel cared for, they feel heard, they feel like we're advocating for their loved one just as we were for someone of our own family member, right? So that process is really important. What are some communication strategies that you can use in this situation? Deborah, I'm not sure if I follow why getting better or why not relief of suffering. I'm not sure if I'm following that. If you want to unmute and explain.
Yeah, doctor, I heard you say, of course we want our patients to get better, and that's not necessarily realistic. So for me, the question may be, what does better mean? And if the diagnosis or the prognosis is that they're not going to improve, if it's a terminal diagnosis, or they're not going to improve to the point at which they are the way they had been before, and if they have goals of care, that can be informative. Why should the emphasis be on getting better and not relieving their suffering? Is that more clear?
Thank you, Deborah. That's helpful. I'm going to have you hold that thought for a moment until we talk about the next one. Okay.
Sure thing. Thank you.
Keep that thought in your head. So there's a lot of great ones coming in. So I love it. So ask about prior experience. So one of the things I've been trying to just get in the habit of, and I'm still working on this kind of own language and how to bring this up, is just normalizing the question that I ask patients and families, which is a lot of people have experienced discrimination or care where they didn't feel like they were being heard or listened to within our healthcare system. Is that something that is that something that's happened to you, and would you be willing to share that experience for me so that I can really make every effort I can to make sure that you get the best care possible? And that allows that to just kind of ask about prior experiences. Again, if I just assume that people have had that experience in our systems, and I ask all my patients and surrogates that I might uncover things that are really important, that might be big concerns that they're not sharing. Yeah, so pronouns and preferences, wonderful. Thank you, Mira. Though these are great. Names, how to be called, all of those things. Okay, so respect. So how ask the person. Similar to the value question. Ask how the person wants to be treated. So I'm looking through these prior experience. So these are great. So I think one of the other really big things that comes up when in some of the literature is There are times, yeah, frequent check-ins are great. Strong. Okay, so this is great. So advocacy. So I'm gonna just, whoops, I'm gonna put those in here. Thank you, Megan. Which I think builds a little bit on what Seiko was saying. How do they want to be treated? And then can we advocate for those? So Megan, I'm going to hold a couple of your other great thoughts into the third box here. But one of the other things I really want to make sure here is that this is a time where we also really need to make sure to explicitly, first of all, acknowledge that that discrimination has happened and take responsibility for it, where we explicitly apologize for harms that have been caused and are being caused. And so those are two of the other strategies I think that are particularly unique to this. So to really acknowledge the harms. So, and let me just give an example of that in a moment, and then explicitly apologize. So if I have a family who says to me, you know, I had a family, for example, one time who felt like a pneumonia was diagnosed late, and that they weren't really listening to the family. They didn't really hear their concerns, and the hospitalist that I was working with, who was very lovely and well-intended, went into this explanation about why the pneumonia was appropriately, or from her perspective, was appropriately diagnosed. How do you think that landed very well? Do you think that the family felt that that was helpful? So that clinician thought there was an information gap, right? It's like, well, if I just explain my reasoning, then I'm going to solve this problem that happened, because I felt like I had really sound clinical reasoning about how and when I diagnosed the pneumonia and how that process happened. But from the family's perspective, they did not feel heard in this. So I was able to say, gosh, it really sounds like you were worried that something was missed, that we didn't hear you earlier. And it sounds like that's a very big concern for you, that we didn't catch this pneumonia earlier. Yes, it was. I am so sorry that we did not listen to you more clearly. We are going to really work hard to get, you know, and that this pneumonia was diagnosed late. Period. I mean, I don't need to get into a whole debate about whatever that is. I can just take responsibility for that and move on, whether that's words that we've used, whether that's experiences. I'm sure Annie, I know I'm thinking of one particular experience where one of her patients had to call 911 from the ICU in order to feel heard. So I think we could go on and on about this. Yeah, about saying I'm sorry is an admission of liability, when in fact, actually what the studies show is that actually if you apologize, you are much less likely to have malpractice suits claimed. So we do not do this enough because we worry about the liability, and we need to do it more often, and we need to take ownership when we have done things both wrong, when we've caused harm, even if they were unintended, right? It's not about intent, it's about impact. So how do we kind of take responsibilities for that, for their experience in the institution? So sometimes it's apologizing for something you did, and sometimes it's apologizing for the royal we, so to speak. Sometimes it's an apology on kind of behalf of the system. Yeah. Okay. So what about family conferences? I'm just looking at the time, so I want to make sure to cover the last one. What do we do about family conferences here? Transparency. Okay. Proceed with caution. Oh, yeah. Okay. Cultural media, which we should always be using, but especially helpful in this if you have them at your institution. I know not everybody does. Ooh, listening. All right, this is great. Yeah. Okay. So these are great. So the other thing that I would also argue is that family conferences may or may not be helpful. I think in these sort of situations, this is really about kind of high touch care is what I would call this. So I think this is when the care is happening at moments, especially in the interstitium. not necessarily in what's happening in a family conference, but what is happening in even the moment-to-moment care. One of my families last summer, actually, who I'm still in touch with, who had a pretty traumatic hospital course and felt discrimination during that from our clinicians. One of the things that the daughter said to me after her dad died was, I felt like the nurses, his face, I would come in and his face would be dirty. They wouldn't have even cleaned around around his mouth, or he had, I know. And the reality is, I'm sure the nurse's perspective is, of course, we're cleaning him, we're keeping him clean, but that wasn't and the family felt like some nurses were really attentive to that and some others. And if they were feeling like, my gosh, if you can't even make sure that his face is clean, how can I trust you to take care of his heart failure? So those really moments kind of in between of how people feel cared for, how do people feel listened, do their concerns feel discounted, even in those one-on-one interactions, are really, really important. And one bad interaction can basically tarnish everyone else's. If you got 90% of the people, right, doing everything they can, and you've got a couple of people who just really dismiss something quickly, that's going to be the thing that's going to end up being the thing that they remember most. So it's really a concerted effort about how are we all working together kind of in those high touch points things. And what's hard about these situations and the next situation that I'll show in a moment is that we often, these are often the families that are like, oh my God, because they're all the advocacy and all that. And like, oh my gosh, I mean, they're at the bedside, and it's a lot of high intensity when in fact, and we want to kind of pull away, and they feel that, when in actually, these are the times when we need to be leaning in. So yeah, asking permission. These are all great, Susanna. Thank you. So for time, I'm gonna just show you, because I want to be able to share a couple of other things. I wanted to especially focus on that one. But the last one that I'm gonna put on here, and if you guys can see this, I'm gonna just a second. Can you guys still see my screen? Give me a thumbs up if you can still see it. Okay. So I'll share. Shanitra's gonna share these slides after we're done. And I'm not going to spend as much time on this last one. The last one is when there is a true values discordance. They just have different values than what we might have. Now, these are all separate. Obviously, people can have all of these, and there's a lot of overlap here. But there are times when they just have different values. And in fact, actually, studies show that in the population, there's about 15 to 20% of the population where longevity is the most important thing. And if you were to ask clinicians who work in healthcare, the vast majority of clinicians, longevity is not the most important value for them. So we are inherently going to have situations where our values are different. And so how do we actually put people's values, their values, as the primary thing, even when they're different from ours? And to go back from Deborah's comment, actually physical suffering is often something that we worry a lot about, that clinicians worry a lot about, especially at the bedside. Nurses worry a lot about, well, this person is suffering. But we know from studies, also from our experience, that physical suffering may not be the most important thing. And in fact, actually, for some people, physical suffering is a meaningful part of a journey at the end of life. And so we really need to really understand what those values are around that, so that we can align with those. Because actually, for some people, having CPR, in fact, actually for this family that I mentioned with the daughter, and we ended up, so this patient was on dobutamine, and the team withdrew it because they were worried about cardiac arrhythmias and the patient was dying. And she saw his cause of death as the stopping of the dobutamine, not because of something, right? So if we withhold things, does a family interpret that as the cause of death, rather than us worried about doing that intervention and then them seeing that they died despite us doing everything? So anyway, things to think about. I think we've put a lot of other things in here. I've put some other kind of strategies in here. I've talked about emphasizing what we are doing. So these are the things that we are doing, and that we are doing everything. Setting aside our own agenda is really important here in these, right? We talked about advocacy. Clinicians, continuity of clinicians or trusts are also really key. Are there community members that are trusted allies for them? Actions over words are really important. And small frequent visits, we've mentioned cultural mediators, and consistent information. We really need to make sure that we're all on the same page as well, and consensus about what we're offering and what we're not offering in these. Okay. Great. Yeah. Okay. Great comments in the chat box. So with that, I'm gonna open it up for a little bit for just discussion. I've got about 10 minutes. I want to save a couple at the end to just share a couple of resources with you guys. But do people have any, just what's coming up to the surface for you? Questions, comments, thoughts about experiences? Feel free to unmute.
Hi, Caroline, Dr. Hurd. This is Erica. I think that sometimes what we see as hypervigilance at bedside might be family culture, right? Like I know in my family, it may be seen as hypervigilance, but we never leave somebody alone in the hospital. Like that's just the way that it is. And part of it is because there is a family distrust of the healthcare system, but part of it also is that we just never leave somebody alone.
Yeah, I think that is a really good point. Is I'm thinking about, we think a lot about kind of individual and family culture. And I think that's where like asking about that. I think on the flip side, we can make the assumption that because somebody's not at the bedside, that they don't care or they're not worried about it, when in fact it's because they don't have any transportation,
Exactly.
they're working 2 jobs, right? So all of those things, if we don't kind of elicit what is this family's kind of way of being, that we won't recognize those.
Yeah, and sometimes that then that ends up being used against this family. Well, this family is always at bedside and they're hypervigilant. They don't trust us, when really maybe that's not what it is. And then, like you said, the conversely is the same.
Excellent. Thanks, Erica.
Doctor, I think one of the things we have to consider, this is Deborah, one of the things that needs to be taken into consideration is the faith, spiritual values, beliefs that are undergirding the family decision making, and how those can be at odds with the teams, and what happens when those intersect.
Yeah, I think definitely. And I think similar to what Arka was just making the comment about family culture, right, is we also know that faith and beliefs are not all, just because somebody might identify with a particular faith tradition doesn't necessarily mean that they hold the beliefs of kind of the larger group or the individuals within that. So this all goes back to, again, what's the person's individual, or what's the family kind of faith perspective that we're trying to understand. Yeah, hold to build empathy in staff, with staff. Yeah, right. Yeah, so Jennifer brings this up is, so which is the challenge, I think, right, is how do we, while we really want to honor where the family is at and where surrogates and patients are at, and also recognizing that it's still really hard. It's really hard to do this work, especially for staff who is at the bedside the majority of the time, right? So how are we making sure that we're empathizing with our teams while helping them build skills around how to manage that when they're at the bedside facing that? Any other comments? Okay. All right. So I'm just gonna share my screen again, and Shanitra's gonna have me share a QR code in just a moment. Before I do that, she's also gonna I think put in the chat box just an evaluation for today. Thank you guys for doing that. I do want to just kind of bring up a couple of just resources to think about in terms of kind of prognostic, in terms of kind of these five kind of core areas. And again, there's lots of others. We just talked about those today. But when the discordance is information, one of the things is kind of how people get information. So a lot of surrogates report that actually the majority of the information is from their nurse. A quarter of people report inconsistent messages, and then a big portion of these report hearing that multiple times. And that this often occurred in the very early part of the ICU stay. So how we can be better about managing uncertainty early on in a hospital stay that leaves things open enough, that expresses worry but also acknowledges uncertainty early on, and how can we try to make sure that information is being clearly communicated across the team is important. We talked about kind of the strategy of sharing headlines and making sure that big picture information is coming across. when the discordance is grief. So there was a great study, again, by Doug White, who's done a lot of work in this. This was in the New England Journal in 2018. This was a nurse-led intervention that actually had a nurse really provide, and an interprofessional team provide support along the ICU stay to families. And one of the biggest interventions that I've highlighted here is emotional support. And this trial was effective both in terms of families rating, surrogates rating quality of communication and outcomes. And so one of the key interventions here, right, is that being able to respond, that emotional support that is so important. We've talked about the nurses tool. I think a lot of people are familiar with that. And then don't bury your empathy. Tessie October is a pediatric intensivist who does incredible work in this and has looked at oftentimes our empathic statements are buried in medical information. So how do we explicitly really respond to emotion and have it just be that and kind of separate from some of that other information sharing piece? When there's a discordance in experience, this study just came out. It was in, I think it was 2020 or 2021 actually, on time trials and looking at the significant effectiveness of time trials. So I'd encourage you to take a look at that study, which kind of highlights how do we, again, how to set up a time trial, what's involved in that, and again, showed benefits of that. These are some of the key things. Do you have a time frame? What are signs of improvement? What are signs of worsening? And what is the plan based on the outcome of the trial? Around discordance, there's a lot of tools related to this. I'm looking at the time. Oh, I'm doing okay. I think we can really get into kind of these cycles when people have experienced discrimination. There's a racially charged or vulnerable moment. There's a biased response to that and how we respond to it, which further actually creates, right, distress, disengagement, and then further activates our biased response, right? And then we kind of end up in this loop. So what are some ways this particular study talked about this emotional rapport? Some of my interprofessional colleagues have said rapport can feel like something we are taking from people, which is an interesting, I've really thought a lot about that, but how do we build relationship and trust, I think is an important about this, which is our emotional responsiveness is really the key to kind of breaking this cycle, right? And how do we practice mindfulness, acceptance, convey understanding, validate experiences so that we can kind of try to promote the cycle in a different way. These are some of the tools: partnership, empathy, apology, respect, legitimation, support are all things we talked about. And then the discordance on the values and beliefs, I won't talk about this in a minute, but I'll just share, this is one of my favorite editorials. I actually found out Scott Stonington was actually a medical school colleague of mine. He's a medical anthropologist, and he's done a lot of work in Asia. And this is a fabulous article. It's one of my favorites that talks about the debt of life. We talked about process versus outcome. If you're not sure what I'm talking about when I mean that, read this editorial and you will get that. So some other resources, I've mentioned Vital Talk. Impact ICU is around especially nurse-led interventions, our graduate certificate in palliative care. And AHPM has a ton of resources. I know Rashmi Sharma, who's one of our faculty, has worked a lot on the resources and this group around diversity, equity, inclusion resources that are there, and some references I've put in. So while I share the QR code, if you want to put in one thing that you're going to take away from today into the chat box that you're going to use in your practice, share that with us. We'd love to hear it. And then I'll leave that QR code for evaluations with that. And thank you guys so much for the discussion.
Thank you so much, Caroline. That was amazing. I think a lot of folks on this video conference are probably doing a lot of the things that you mentioned, and then so many other things that we can learn and employ and use in our everyday interactions with our patients and their families. But what I think is just so incredibly brilliant too is even if we're already doing some of these things, just putting it in that context and naming and framing is so incredibly important, because without that, we can't teach these things, these tools, these strategies, these skills. And just really what a great talk, which I think is being echoed through the chat. So thank you again so much. And for our applicants, welcome. And I know Shanitra will be moving you into your introduction with me. So I'll see you in a second. Thank you again so much, Caroline.
Thank you. All right. Thank you.